for 5 minutes.
Thank you. Thank you, Mr. Chairman. I appreciate it very much. I want to thank the witnesses for testifying today as well. Uh, Dr. Grimm, clinical trials often provide patients with the best, perhaps only treatment option for their condition. However, without coverage or routine costs associated with participation in clinical trials, many Medicaid beneficiaries do not have the latest technological, and scientific advancements as a treatment option. Medicaid serves many demographics, including tribal communities, that are underrepresented in current clinical trial enrollment. Lack of participation in clinical trials from the Medicaid population means these patients are being excluded from potentially life saving trials and are not reflecting the outcome of the clinical research. Congressman Lujan, my good friend, and I introduced H.R. 913, the Clinical Treatment Act, which would address this issue by providing coverage of routine care costs associated with clinical trial participation for Medicaid enrollees. And this is a question: does increased access to clinical trial participation for Medicaid enrollees help ensure medical research results more accurately capture and reflect the population of this country? And if so, why is that important? And especially if we develop better treatment options and a vaccine for the COVID 19. That's a question for Dr. Grimm, please.
Thank you, Congressman. You're absolutely right that there's been underrepresentation in a lot of clinical trials of all minority populations and Medicaid eligible patients. One of the reasons that it's so important is that if a new drug or a new treatment is not tested on a specific population group, whenever that medication or treatment comes out, doctors ask themselves, especially doctors in Indian Health Service, they'll say, there really wasn't a significant or any Indian population in this particular trial. How do we know this drug is going to work the same on our population? And that goes across the spectrum of almost anything. So I think it's extremely important. Although I've not read your full bill, I support the concept and I appreciate the question.
Very good. Thank you. I appreciate the answer. Dr. Grimm, according to the NIH, diabetes is a common risk factor for peripheral arterial disease, or PAD, a circulatory deficiency that leads to blockages in the blood vessels that supply the lower extremities. Native Americans experience both diabetes and PAD at a disproportionate rate. And in certain regions of the U.S., Native Americans are more likely to undergo a PAD-related amputation than Caucasians. Patients who undergo amputations have shorter life expectancies, of course, and exchange independence and functionality for chronic physical ailments, high death rates, and a costly dependency on our burdened healthcare system. However, most of these amputations are preventable if PAD is screened, diagnosed early, and properly managed. And I've actually witnessed a procedure. It's really incredible what we're doing today. Because tribal communities are disproportionately affected by PAD, what steps can be taken to ensure that these communities, even in the midst of a pandemic, have better access to quality care that will prevent such amputations? If you could answer that question, sir, I'd appreciate it.
Thank you again, Congressman. Amputations specifically, I'll talk about in Native communities is higher, as you pointed out. And it's terrible when the disease reaches that state where there's no other way to treat it. Because of the isolation of many of our communities and the ability to get either the specialist for that sort of care or to recruit people to your community to actually work, those are very difficult hurdles to overcome. And just off of the top of my head, and I'm willing to research this further, but I feel like the agency would need more purchased and referred care dollars those dollars that we use to refer to higher level specialists for care that would help our population. And the other thing that was mentioned earlier too is the approval of the bill that would extend a longer term to the special diabetes program for Indians and also raise the dollar amount on that. That program has done an immense amount to reduce the prevalence and the incidence of diabetes in Indian country. And as you pointed out, that's one of the primary factors that causes a higher level of this disease in our population.
Yeah, it really sounds, this is common sense. I know we could save a lot of money as well because amputations and the care afterwards is very expensive. But it's a quality of life issue. Mr. Chairman, I'm not sure if I have any more time. I don't see the clock, but I have one more question if I have time. Is
You
that
have
okay?
time. Yes, you do.
Okay. All right, very good. I appreciate it. Ms. Sage, your testimony talks about some of the issues tribes have had in accessing the Paycheck Protection Program, the PPP funding. Specifically mentioned the disparities between tribal businesses and large corporate chains. Can you tell us more about this? And what would you propose to fix the administration of PPP? Now, I know we made some tweaks to it, and they've been very positive. But what else can you add? Thank you. And this is for Miss Page. Oh, excuse me, Miss Sage.
Thank you for that question, Representative. With that, we will allow multiple entities to apply under one EIN. And that was my answer. Thank you.
Thank you very much. All right, Mr. Chairman, I yield back. Appreciate you holding this hearing. Thank you.